the second edition of the Pediatric Spine Academy India webinars. And after the first Super edition last year with over 500 registrations, we began our second session here, and this time along it's bigger. And we start with our first topic, which is one of the most interesting topics, that is pediatric back pain. And this time again, we have more than 50 registrations to start with. So over to Dr. Arjun Dhawale to start with the proceedings.
It's my pleasure to welcome Smit, who is Assistant Professor of Surgery in the University of Ottawa, and his main interest is pediatric spine. He's a pediatric and spine surgeon at the Children's Hospital of Eastern Ontario in Ottawa, with special interest in scoliosis and the teether. And this is a great topic to start with. The evaluation assessment of back pain. And looking at various causes, and how would you sort of go further in terms of looking at them in the clinic and then investigating and managing. So without any ado, I'll hand over proceedings to him.
Thank you very much. Can you see the screen?
Yes, we can.
Excellent. First off, thank you so much for inviting me to give this talk. It's a real pleasure and honor to be involved with the Pediatric Spine Academy of India and POSI. Recently was at POSICon 2025 in January, and absolutely had a blast. And the relationships that we've established through the Pediatric Orthopaedic Society of Canada and POSI have been really outstanding. And I know that we're having the opportunity to collaborate more and more with fellowships in various projects. And I'll give you a little talk today about pediatric back pain. And there'll be about a 10-15 minute period for questions at the end. Let's see if I can advance. Okay. I have no disclosures directly related to this talk. Apparently, it doesn't pay much to just treat pediatric back pain, as I'm not a physiotherapist. But I do receive some institutional support for various projects that we have. And, another disclosure is I had an absolutely phenomenal time at POSICon this year, and look forward to having an ongoing relationship with India and the Pediatric Orthopaedic Society there. Let's start off with a case, and this is something that we see quite often here in Canada. This is a case of a 15-year-old male, healthy, that presents with low back pain. It's really been going on for 3 months. It's worse when he plays cricket. And thank you for introducing me to cricket. I had a really good time at POSICon, attempting to bowl and hit the wickets. Now, this guy comes in. He has no major radiculopathy. He's paraspinal pain. He otherwise has a normal exam. And so, I'm sure this is a presentation that comes up very often, is really, what do you do? Oftentimes, they'll be presented to us as pediatric orthopedic surgeons already with radiographs. And the radiographs will be normal, right? And so, so what are you going to do? And today, our objective is to really talk about pediatric back pain. We're going to review an approach to pediatric back pain. We're going to outline what red flags and what symptoms you should not miss. And I have quite a few cases of what not to miss in pediatric back pain. And again, this is a great picture from the drum circle that we had at POSICon. So in terms of approach to pediatric back pain, everything starts with the history and physical. We are physicians first, and most of the time, a good history and physical exam will help lead us in terms of, is there something bad going on or not? And we'll go over a few of these red flags, and on your physical examination, it's really important to be able to do a good physical examination of your patient. I usually just have them kind of walk across the room, walk on their toes, walk on the heels, sit on the ground, stand up, jump, get them on the exam table, check their reflexes, check their basic strength. And if a kid is moving up and down, it's probably not something very severe. Where if they're getting up and moving around like an 80-year-old lady, then it probably makes you think that, okay, there's something else going on. So if we follow this algorithm in terms of the history and physical, and you have normal findings, no concerning features, then I usually start with non-operative treatment. The vast majority of the time, after 6 to 12 weeks, they will improve, and then you're good. You don't need to see them anymore. Fantastic. Come back if needed. Now, if in your non-operative management, after 3 months, they haven't improved, then you may want to consider radiographs. And then I'll come back over to this side in a second. But the radiographs is really, okay, you trialed non-operative management. So now let's look into things a little bit more. Now, what happens on your history and physical if they're abnormal or you present with any of these red flags? So any abnormal findings, hyperreflexia, weakness, radiculopathy going down a leg, fevers, chills, weight loss, all those things get us thinking that maybe there's something else going on. I always like to start with screening radiographs. I'll usually get full spine radiographs unless it's really focal pain in the low lumbar spine. Then sometimes I'll only get a lumbar spine x-ray. And I like to get the whole picture because sometimes if you concentrate too much, you may be too focused. And you want to also look at the global spine alignment because sometimes you can see other compensatory measures within the spine. But, so if you get normal x-rays, and again, they're normal and you're not too concerned, then I'd continue my non-operative management. But, sometimes the radiographs will be normal, but you're still like, something just isn't right. Something doesn't sound right. This patient's been having pain for a year. Let's just make sure that nothing else is going on, that we haven't missed anything. And that's when I will investigate a little bit further, either with a CT or MRI, depending on what my main etiology is that I'm thinking about. If I'm thinking more kind of spondy, something like a fracture, then I'll get a CT scan. If I'm thinking more soft tissues, I'll get an MRI. And I just want to point out that, if you have abnormal findings, red flag symptoms, x-rays that are abnormal, then you have to investigate and treat. And it's important to investigate appropriately with a CT or MRI, and sometimes both. And so what is the non-operative management? Well, I go by the 4 Ps. So my first one is prevention, right? I think a lot of it has to do with better sleep, avoiding activities that exacerbate the pain. So it's kind of lifestyle modifications, taking them out of sports, especially in kids. It's usually sports that are the main driver in North America, especially things like football, gymnastics, dance, cheer, and really promoting a healthy lifestyle. There's psychosocial aspects as well, and it's important for them to be educated in terms of their mental health, making sure that they're getting the right amount of support. If they're very stressed out at home, at school, if they're being bullied for any reason, it's important to give them that social and psychological support. Now, I'm not very good at that, but I have some team members that do help me with it, so I appreciate that aspect. There's a physical aspect, and I think this is one of the most important things, is that physiotherapy and exercise is probably the main tool in our toolbox that we can use to help these children with kind of non-specific mechanical myofascial back pain. It's really getting into a good physical therapy program, learning good exercises, and doing them on a daily basis. And sometimes, if I'm investigating and they have ongoing pain, it's like, listen, I have no idea what's going on. And so you got to find something that helps you. And sometimes that can be anything from massage, acupuncture, chiropractics, electrical stimulation devices, hot, cold, different therapies, pool therapy. So it's really finding the best treatment for that patient that works for them. And then there's also pharmaceuticals. I usually prescribe anti-inflammatories. So I'll start with ibuprofen. If I need to, I'll prescribe something a little bit stronger. And I also often prescribe, especially in Canada, probably not as big of a deal in India, but we don't get as much sun up here. And so I'll often prescribe vitamin D. And I think vitamin D is important for bone health and bone development in these children. And so I say that the stronger your bones and the stronger your muscles are, the less likely they are to hurt. And it's important as well, sometimes, especially if they're in an acute pain crisis, to give kind of that 4 to 6 weeks of continuous anti-inflammatories to try and get out of the pain cycle. So there are various different exercises that can be used and prescribed to help relieve back pain. Again, it's important to have a few physiotherapists that are your go-tos that you trust that will spend the time with these kids and their families to teach them appropriate exercises depending on where their pain is and what their symptoms are. And in my clinic, I always tell kids that physiotherapy is like brushing your teeth. And most kids, they brush their teeth every day, right? And so you should do it on a daily basis. You don't just brush your teeth when you're going to the dentist. And so that's kind of my spiel to them, to get them into the mentality that it's important that they do these exercises every day as part of their daily routine, just like brushing their teeth. And their teeth usually don't even hurt, but they brush them anyway. So I'm like, and your back hurts, so you better brush your teeth, or better do your exercises. And I put it in the note that if they don't do the exercises and they don't listen to my recommendations, then I'm not going to listen to them complain, because if they're not doing their part, I'm not going to have to do mine. And I always make sure that they don't get confused and start brushing their back with a toothbrush, because that is not very efficient. And so it's important to decipher what is back pain that you don't have to worry about versus back pain that is a lot more concerning. And that's when we start talking about these red flag symptoms. These red flag symptoms in me is when you're thinking about fever, so you're thinking about potential infections. That's a red flag. If the patient was involved in a recent trauma, right? And what kind of trauma was it? Was it a motor vehicle collision going at 100 kilometers an hour and people passed away at the scene, right? That increases your thought process that maybe something bad is going on, versus some insidious onset low back pain that's been going on and progressive over 3 months. You want to look at serious red flag symptoms like saddle anesthesia or urinary incontinence or retention. That's suggestive of pressure on the spinal cord, or at least at the cauda equina. It can lead to cauda equina syndrome. And then any other red flags for potential cancer diagnosis. And this could include fevers, weight loss, feeling more fatigued, development of a mass. But oftentimes, from the patients that I've seen that have had childhood cancers, they don't always present with those kind of classic red flag symptoms, except for some progressive pain that's not responding to the anti-inflammatories and getting worse and affecting their ambulation. Now, I've also put these kind of yellow flag symptoms, and these yellow flag symptoms for me are all the ones that also get me kind of something else is going on. When you think about kids that are having night pain, the pain's waking them up at night. If they're getting radiculopathy and pain going down the legs, or the pain has been really worsening despite non-operative management, like something else is going on, or if they're missing school or missing different activities because of this, especially in Canada, if the kids are missing hockey, you know that it's a big deal. So probably similar if the kids are missing cricket back home. So these ones raise my suspicion that something else is going on besides just mechanical back pain. So for the next part of the talk, I'm really going to concentrate on what not to miss, right? We're going to go over a few key presentations on their history or their physical that kind of clued us in that maybe there's something else going on and we should investigate it a little bit more. So when we're talking about pediatric back pain, there's a ton of differentials. It could be anywhere from mechanical disorders, from a herniated disc, muscular disorders, overuse syndrome, postural problems, or even potential vertebral fractures. It could be developmental disorders like a spondylolysis or spondylolisthesis. It could be Sherman's disease, spina bifida, occulta. Now, sometimes there's debate whether that causes pain or not. And same thing with scoliosis. I mean, people with scoliosis, especially as it gets bigger, they can have some back pain. And so those are all important things to tease out. A leg length discrepancy, especially if it becomes more than 2 centimeters. It could also be secondary to an inflammatory process or infectious process like a discitis, vertebral osteomyelitis, an epidural abscess, something like ankylosing spondylitis, or an SI joint infection. And kind of what we worry the most and what we don't want to miss is a neoplastic process. They could be anywhere from a benign bone tumor to a malignant bone tumor. It could even be a spinal cord tumor itself. And very rare in pediatric patients that they present with metastatic malignancy. So let's dive into a few cases. This is a 13-year-old male, slipped on ice. I guess that's not really a problem that you have in India too much, but we definitely have it in Canada. Where he presents with some kind of low back pain. It shoots down the left leg. He's been having trouble walking ever since. And when you examine him in clinic, he doesn't quite move very well. Uh, he's slow to kind of get up off the ground when you have him sit. His reflexes are a little bit down on the left leg. He's got a little bit of weakness in his foot. And when you go to do a straight leg raise and bring that left leg up, you can only bring it to about 30 degrees before he starts having pain and doesn't want to go higher. And when you bring the right leg up in a straight leg raise, he gets radiation pain down the left leg. So that's another clinical exam finding that's pretty important for this. And so when you put those things together, you're like, okay, there's something going on. He presents with a left-sided radiculopathy. We should investigate this a little bit more. And on the MRI here, you can see that it is a left-sided L5-S1 disc herniation. You can see that nucleus repulsus has come out. It's impinging onto that left-sided nerve root. It's pretty prominent. And, he failed a few weeks of non-operative management. But when I start seeing weakness in these kids, it starts getting me a little bit worried. And so that's one thing where I'll try some early non-operative management, but if there's not improving drastically fast, then I will pull the trigger a little bit earlier on them. And oftentimes we'll also get a CT scan, and why the CT? Well, just wait till the next case, and that'll answer the question for that, because it does change a little bit my approach and the treatment depending on what we find. And so this individual underwent a mini approach, a left-sided L5-S1 discectomy, where we just went in, took off the disc. He had almost immediate relief of his symptoms and did well there afterwards. So in pediatric disc herniations, I usually treat them with initial physiotherapy, anti-inflammatories. Oftentimes I'll have a lot of muscle spasms, so I will give them a muscle relaxant for the first couple of weeks. And usually it does improve within 6 to 12 weeks. Red flag symptoms for me is major radiculopathy that lead to weakness, and especially the bowel and bladder symptoms. It's important to get on those fast if you're worried about a Cauda-Equina syndrome. Here's another young lady, a teenage girl that presented after a long-standing history of lumbar back pain. She'd been seen by many people. I was given physiotherapy, anti-inflammatory. She hadn't improved over 6 months, saw me, and I kind of kept on up with the non-operative management. And she get intermittent pain going down her left leg on occasion, but she was just miserable. She was not going to school anymore. She just didn't want to participate in any sports. And so we investigated her. And again, here you see another L5-S1 disc herniation, but this one's slightly different than the other one. And if you look really closely down at S1, you're like, okay, there's something that's being elevated off the posterior aspect of S1. And this is what the CT scan confirmed. And this is kind of one thing that you have to look for, especially in pediatric patients, is this is a L5-S1 disc herniation, but with a slipped S1 apophysis. So this is a ring apophysis that goes around the vertebra. And this is how the vertebra grow. It's kind of like the growth plate. It's kind of like a Salter-Harris fracture. And what happens is a piece of bone goes with it. And so if that piece of bone goes with the disc, if the disc over time resorbs a little bit, that piece of bone is going to stay there. And these patients are a lot less likely to have resolution of their symptoms without non-operative management. And so I'll be a little bit more aggressive with them because this is a true kind of bony disc herniation as opposed to a pure soft tissue herniation. And so the treatment's just a little bit different too, because we'll go in and on this patient, we did a left L5-S1 open mini discectomy. We also have to go in and take out that apophysis. So you need an osteotome. You have to come across that back of S1 to take off that extra piece of bone that's there. Because if you fail to do so, the patient will not have resolution of their symptoms. So when we're talking about these slipped apophysis, I treat them similar initially to disc herniations, but I'm much more aggressive if they're not showing rapid improvements in their symptoms because they're less likely to improve with non-operative management. And again, this picture just highlights the position of the ring apophysis, how its influence on growth and how it's related to the disc, and when it comes out, that can be pushed out. And kind of similar red flag symptoms as our disc herniation that we previously talked about. Looking at another case of a 10-year-old female, she's a gymnast. She presents with low back pain that's been going on and off for 9 months. Worse with gymnastics, worse when she goes into hyperextension. She's been in physiotherapy for 3 months, taking ibuprofen on occasion. Presents with a normal neurologic exam. Right. And we get x-rays. Sometimes, especially the lateral x-ray is a little bit hard. You can give these oblique x-rays and look at the Scotty dog, and you can see here she has a unilateral defect in her L5S1. And she might have a little bit of inflammation in that on the other side as well, where it's a little bit thicker and more white. And you can see that she may have slipped just a little bit anteriorly in terms of L5 on S1. And so I do like to investigate these in more detail with a CT scan so I can better characterize what it looks like. But this is an example of a L5S1 grade 1 spondylolisthesis, right? And when you're looking at the CT, you're really looking at the pars defect at the level of L5. You want to look if there's any slippage or not, so that you can characterize and try and figure out what's going on. Sometimes these can be very tricky. When you're talking about spondies, especially the ones that haven't displaced much, sometimes they're hard to diagnose. You have to have a high index of suspicion on your history and physical. And a lot of it is that history. It's kind of that low back pain. It's really localized focally at that lumbosacral junction. Sometimes the x-rays and the obliques can be completely necessary. And therefore, if they're not improving over time, I'll consider a CT scan for the diagnosis. And sometimes they only have a strain at the level of the pars, and you can only pick that up on an MRI. And sometimes with the MRI, like you can see here, you can see that inflammation of the pars without necessarily an acute fracture. And again, it's important to diagnose if this is more acute or chronic. If it's a kid that comes in and gets hit hard into the boards, playing hockey, comes and has acute pain, I may treat them with rest, remove them from sports. And these are the ones that I would actually consider a lumbosacral orthosis or even a TLSO, because there you can try and get it in a better position and potentially heal them. Give them anti-inflammatories and get them started in physiotherapy once the pain subsides. And again, I think the most important thing to tell these families with these spondies is that our goal is to manage the pain and not necessarily manage the radiographs or the CT or the scans, because they won't always heal with a bony bridge. And sometimes they'll just, what I tell the families is that they'll form a scar in between, and that scar will be as strong as bone. And as long as it doesn't hurt, then it doesn't matter. And so, what does it mean if they failed? Well, if they have persistent symptoms for more than 3 months, despite good physiotherapy and anti-inflammatories, I'll investigate them a little bit more to see if there's any healing or if there's any ongoing progression. And, if they're minimally displaced spondies, I'll consider a PARS injection. And I'll have that done with interventional radiology, where they put needles in and inject them to see if that's what the source of the pain. And if it is, there's various ideas for surgical treatments, including direct repairs, screw hook construct, wiring. You can do an MIS kind of guided PARS repair, or even an L5S1 fusion. So these ones become a little bit more obvious, like we're seeing in this case. This is a 10-year-old female that has low back pain. She has a little bit of intermittent right radiculopathy that's been getting worse. Um, I'll just assume until somebody says they can't. And so here again, you can see that she has a fairly high grade L5S1 spondylolisthesis. I like to get CTs and MRIs on these patients to look. And here again, you can see some dysmorphic changes of the L5 and S1 bodies. You can see over 50% slippage on this. And basically, so this is a high-grade spondylolisthesis. And for this one, we treated her with an L5-S1 decompression. It's important we did a big L5 nerve release to see it go all the way through. I like to do instrumentation from L4 to the pelvis for these big high-grade spondies. I did an L5-S1 reduction because she was not very well balanced. We were able to put in an L5-S1 interbody cage and a lot of grafting. And she's a lot better post-op and doing well. And that's her 6 months after surgery. And this is another kid with another high-grade spondy, almost a spondyloptosis. He's 13. He presents with low back pain, again, intermittent leg pain, and he can't play hockey. And so on the history, that's a kind of a big red flag for me is when they're stopped doing their main sports because of the pain. So again, we investigated him. He has even more dysplastic features. You can see that he's got some kyphosis, some focal kyphosis here, where the sacrum's in extension. But this really high grade, this one makes it a lot more difficult to get a knee reduction, but he was fairly well balanced globally. And so with this high grade spondylolisthesis, with this amount of deformation, what we ended up doing was an L5-S1 decompression. We put in our screws, we did an L5 nerve release, we did instrumentation from L4 to the pelvis. We did kind of prep the disc, as you can see here, but it would not reduce, and we didn't try reducing this one just because of the severity of the slippage and the changes on the CT. So we didn't. So instead, we try to correct a little bit of that, like that low focal kyphosis. And then one technique that I've been starting to do is get this large screw that really goes through S1 into L5 and get it a really nice strong fixation to support it, and then significant bone grafting to get it to heal. And this is him 6 months post-op. He's got good sagittal and coronal balance. And he's doing extremely well post-op, and he wants to go back on the ATV. So again, when you're approaching lumbar spondylolisthesis, the major question that you have to have here is it a low-grade or a high-grade slip? And then is it balanced? And there's local balance. So is there local kyphosis? Is the pelvis extended? Is it retroverted? And is there global balance? Meaning is the spine balanced, is C7 plumb line, or is it way off? And, so for low grades, you can do a direct repair, a little bit of reduction because it's not much to bring it back from like a grade 2 to a grade 1 or a grade 0. But if they're unbalanced, like a type 6, then you should try to reduce it if you can to better balance the spine. This is a case of a 13-year-old male that presents with lumbar back pain. It's been on kind of progressive over a week. And he starts having fevers and feeling unwell. There's no radiculopathy. And so here the big red flag is the fevers. So most kids can present with a lot of fevers, but when you see the back pain progressive and the fevers, then you start thinking about the possibility of an infection. And sometimes, especially early on, it's hard to pick these up radiographically. The radiographs can look completely normal as they do here. And this is diagnosed by MRI. He also had blood cultures that were negative. And so here you can see that L4-5 disc space being very abnormal. And, he didn't respond initially to the first set of antibiotics that we gave him. The initial blood cultures were negative. And so, he's not managing well initially over the first couple days. And we just couldn't get a sample. So we actually had our interventional radiologist go in and do a CT-guided biopsy to get a sample. And that grew MSSA. It was resistant. I forget what it was resistant to. It wasn't MRSA, but anyway, we switched the antibiotics, and he got a lot better after a couple of weeks. It's important to follow these kids long term because this is him 1 year post infection, and you can see that he's had is at the 3-4 level. He's had a 3-4 fusion because of the infection. But now he's doing great. He has no pain, no neurologic symptoms, no concerns, back to all his activities, and doing great. And so in pediatric discitis, it's important to make that diagnosis. Sometimes it can be hard. Sometimes they present with a small epidural abscess. Sometimes it can just present with radiculopathy and you think it's leg pain, but always think about the spine. And I'll operate on kids if they present with neurologic deficits, if there's a significant abscess formation, if they present with kyphotic deformity or spine instability. So if the infection goes and takes out the facet joints, or you see that there's progressive focal deformity, then I will go in and consider operating on them. Or failure of conservative management, or if you need a source, but I prefer interventional radiology. The other infection that you have to worry about is tuberculosis. And I know that, especially after our discussions at PosiCon, I know that you guys have a lot more experience with tuberculosis than we do here in North America. So I'll defer that talk to you guys because you are the experts on that. Now, these next couple of cases highlight a few of the other diagnoses that you don't want to miss. This is an 8-year-old female. She's had progressive pain for the last 4 months. She has difficulty sitting. And so whenever she sits, she gets a lot of pain. She can't run anymore. She has no constitutional symptoms. And so after it not improving, they had a radiograph that was done. And you can see on the radiograph that there's this lucency in the S7. Right? It's pretty subtle, not something that you'll always look at, but that's why it's important on your physical examination. You see where the point of maximal tenderness is, and this is kind of right at the cleft of the buttock when you press, and so it will direct your eyes kind of where to look, and then once you see it, it's pretty obvious. So she was investigated, and again on the CT scan, you can see this lytic lesion in the S5, and on the MRI, what you see here and what's the most pronounced thing is these fluid levels. And so when you see fluid levels on an MRI, you always think aneurysmal bone cyst. So EBCs can be fairly common and present in the spine. But to make sure it's a little bit of an awkward area, we want to confirm the diagnosis. We got a CT guided biopsy that confirmed that the diagnosis was an S5 aneurysmal bone cyst. And for this, we went in, did an open biopsy to confirm. We did an extensive curettage and bone grafting. And she's 2 months out and doing quite well. We're obviously worried about a little bit of discontinuity between the sacral-coccyx junction, but she seems to be healing and having no pain, and she's twirling down kind of these ropes and stuff, and we've had to slow her down. This is a 12-year-old female that presents with 1 year of progressive upper back pain. She's seen people, she's seen her family doctor, she's been to the emergency room just because it hurts so much. X-rays are normal. And she starts getting this kind of right-sided arm pain, worse with certain activities, and it's worse at night. So again, now when we talk about this, and okay, this has been over a year, it's affecting her. Sometimes she won't go to school because of it. It's keeping her up at night. It responds to anti-inflammatories. So now you're thinking of another inflammatory process going on in the spine. And so she got investigated. She got CTs, and she was found to have a T1 osteoblastoma. And so, osteoblastomas, osteoid osteomas can present in the spine, and it's important to listen to these patients. It presents really with these classic symptoms of this. And it just grew so much that it started impinging onto her exiting nerve root and causing some radiculopathy down into her arm. And so what we did from a surgical standpoint, we went in, we did an we did an open biopsy through an en-bloc excision. And then because it took out, you can see that it invades the entire facet. And so I was quite worried about potential instability. And so because of that instability and taking out the facet, just because it was so large, we ended up instrumenting level above and below from C7 to T2 and grafting. Post-op, she had complete resolution of her arm symptoms. She was sleeping at night, and she is just ecstatic and very grateful for having discovered what was going on and making her better. Now, this case was a 15-year-old female. She presents with progressive back pain for 2 weeks. She's active in dance and cheerleading. She had a fall at practice. And then the next day, she just wakes up. She's getting numbness into her legs and weakness. She can't walk. She lost control over her bladder. Her pain now is a 10 out of 10. And so when we hear this, I think hopefully a lot of red flags and a lot of alarm bells are going off in your mind. You're like, okay, she fell, she has numbness and weakness, urinary issues, she can't mobilize, she's weak, she has 10 on 10 pain. She's on exam, again, pretty weak in her lower extremities. She's like a 1 out of 5 in terms of motor. You can see maybe a little flicker in her toes. She can't walk. She can't plant her flex. She can't extend her foot. She has decreased perianal sensation, weak, like no rectal tone. And so these are all concerns about cauda equina syndrome. And so she got an urgent MRI. And here on the MRI, you can see some very concerning features. Okay. She has cord compression. Well, I guess it's more nerve root compression at the level of the dural sac. At the level of, that's what, 3, kind of really at 3, L3. And when you look, she has this large soft tissue mass. So she's developed kind of this thing around L3 at the level of the spinous process. A CT scan, again, goes and shows kind of this sclerotic lytic lesion. And so the most likely diagnosis here is something bad. And this is an example of a Ewing sarcoma. So we brought her urgently for surgery. We did an open biopsy and took a sample first of the spinous process at L3. We sent that off to the pathologist, who confirmed a lot of small round blue cells with atypical nuclei, which is consistent with Ewing sarcoma. And so, again, just before we did that, we did talk to our local tumor surgeon. And this is hard because now you're dealing, okay, this is potentially Ewing sarcoma on one hand, but this patient is also presenting with an acute cauda equina syndrome. So what do we do? Because the classic treatment for Ewing sarcoma is chemotherapy, staging, and then en bloc wide resection, which would be very hard in this area. Versus the treatment for cauda equina is acute full decompression of the thecal sac. And so we ended up doing a spinous process resection. We didn't go and try and make sure we took like everything off the dural sac and the ligamentum flavum. We just went down to kind of to the bone where it was soft, did not violate into the canal. And so basically we did an indirect decompression to take all that pressure off. And then she was treated with chemotherapy and radiation. It took her about 2 months, and then she was able to start walking again after that decompression. But she definitely felt a lot of relief immediately post-op. Unfortunately, she has been diagnosed recently with some metastatic disease and is currently being treated for that as well. So pediatric spine tumors are a potential diagnosis when we're evaluating children with back pain. The most common ones involving the posterior elements are osteoidosteomas, osteoblastomas, and aneurysmal bone cysts. And from a malignant standpoint, I think Ewing sarcoma. And they can also develop on the posterior elements osteochondromas. When you're talking about anterior elements, you're thinking more potential giant cell tumors, osteosarcomas. You can get aneurysmal bone cysts as well. And you can also think of eosinophilic granuloma, which is another common diagnosis that we can see in the pediatric population. And those kids usually present with vertebral plana, where the whole kind of vertebra just kind of collapses down. Show you a little case of a 16-year-old female that presents with some low thoracic back pain. It's been going on for 4 years. She's extremely bothered by the appearance. She says she has a big hump in her back and that nothing has helped. So she has been miserable. She's not participating in sports. She doesn't want to go hang out with her friends. She misses school because of this. She's tried physiotherapy. She's tried bracing. She's tried everything, and is really just very miserable. And so she's diagnosed with Sherman's kyphosis. And here, by definition, Sherman's kyphosis is 3 levels, 3 consecutive levels with more than 5 degrees of anterior wedging consecutively. And so by definition, that's what Sherman's kyphosis is. And so you can see here that she has at least 4 levels that meet that criteria. So we've investigated her and we worked her up, and you can see that the bones are abnormal. You can see these Schmorl's nodes anteriorly. You can see the end plates are abnormal. You can see the discs, they don't look healthy. They look quite ill. And so, these are leading issues in teenagers, especially in terms of the cosmesis, but also the pain. And the pain's real. I mean, it really prevents them from doing a lot of their activities. And so after a lot of counseling back and forth, making sure she was ready, we ended up proceeding with a posterior spinal instrumentation fusion from T3 to L3. We did a lot of multiple Ponte osteotomies to really close down those posterior elements. I like to use navigation for these cases and a lot of bone graft. One of the keys, especially when you're planning out your levels for Sherman's kyphosis, is to make sure that you take the sagittal lumbar stable vertebra. So that's a plumb line straight up from S1 where it intersects, because you don't want to stop short. Otherwise, you'll get add-on or adjacent level kyphosis. You don't want to start too short at the top either. Otherwise, you can get PJK, proximal junctional kyphosis. So just a couple little things. The role of Ponte osteotomies for those is really taking out those facets and cleaning it up so that you can get more compression on those posterior elements. I like to use a cantilever reduction technique where I'll put in the rods and then gradually cantilever it to get it corrected in the sagittal plane. And the last couple things that we'll talk about is a couple trauma cases. This is an example of a 15-year-old female. And the driving age in Canada is 16. I must admit, I was very impressed by a lot of the driving ability when I was in India. It's kind of crazy at times, where people just kind of go in and out of traffic. It is really amazing. But she got in a fight with her boyfriend. She had been intoxicated and crashed at over 100 kilometers an hour. She was transferred to the emergency room with significant lumbar back pain. And here you can see on the CT that she has this flexion distraction injury. So on the front, it's kind of like a seatbelt injury where she flexes in the front and then distracts the back. And you can see that she's broken all the way through the pedicle. And so this, by definition, is an L3 bony chance fracture. What I'm not showing you is the other side, where she, instead of fracturing through the pedicle, she's actually fractured through the facets that render that joint unstable. And if you have just a true bony chance, you can actually just compress it and it should heal. But because she broke through the facet, we had to go and do an open reduction internal fixation with instrumentation from L2 to L4. And we had to fuse that L2-3 facet joint on the other side just because it was so it was unstable. But again, if it was a pure bony chance, you could actually just instrument L2, instrument L4, compress, and then eventually take out those rods so that they don't have that lumbar stiffness from the fusion later on in life. And this is a 14-year-old male that had a dirt bike crash. He went over a big jump, probably about 10, 20 meters in the air, and then landed really hard. He had immediate thoracolumbar pain. Wasn't able to walk, was transported via EMS. And when you look at these x-rays, you can see that he has, I think it's an L1 burst fracture, and you can see that retropulsion of the body posteriorly. And so when you examine him, he presents with hyperreflexia. And so he has big reflexes, a little bit of clonus in his feet. And so that's concerning for me, that there's impingement onto the bottom of the spinal cord. And so he gets a CT scan that shows that anterior compression, but with the burst component where part of the body is extruded into the canal. His MRI confirms that there's compression of the conus, and that's what's leading to his abnormal physical exam findings. And he ended up undergoing, so here are the differences, that you have to do an L1 decompression. And so you have to take those posterior elements of L1 off. I was able to move the thecal sac out of the way and take a punch, like a bone punch, and then hit in the posterior L1 body to translate it anteriorly and take the pressure off the thecal sac and better align it. And then he had a few other injuries, so we ended up instrumenting him from T11 to L2 and then fused them. One big difference I find in kids is that, in adults, sometimes you need longer constructs because the bone stock is not as good. But these children's bones are very strong, and you usually get very good purchase. And so I was not worried about having a smaller construct on him. And this is him 1 year post-op. He's back doing all activities, no pain, doing very well. And I think the last case that I wanted to share with you is this young girl. She's 12. She fell from a bunk bed. And she has a lot of lumbar pain. She was transferred from an outside hospital with a normal neurologic exam. And so, what's important when you're also talking about spine trauma in peds is that, okay, she fell from a bunk bed. So she fell from maybe like a 2 meter height. No kid should break their back by just falling from a small height. And so it's important to do an adequate history and physical exam because here it just doesn't make sense. You'd expect her to fall out of an airplane to be able to get a fracture like this. And so what we ended up doing is this was deemed unstable. Again, she has a bony chance with the multi-level unstable lumbar fractures. So we did an L2 to L5 instrumentation and L3-4 fusion. And the most important part for her is that we actually put in a referral for our bone health team. Intraoperatively, we could find that her bones just weren't that strong. When you're putting the screws in, they just feel soft. And she ended up having not necessarily osteogenesis imperfecta, but along those lines where she was found to have a mutation, a genetic mutation that led to her having decreased bone mineral density. And because of that, she got bisphosphonate treatments and improved over time. So I think the most important thing there is that, listen, something's abnormal with the history, something's abnormal intraoperatively with the feel when you're putting these screws in. And we were able to do that and hopefully prevent further fractures down the road. So for pediatric spine trauma, it's important. My indications for surgery include neurologic deficits, spine instability, and there's some scores on the adult side that you can kind of apply to kids in terms of the TLIX score. You can have excessive deformity, so if you have too much kyphosis or scoliosis, you may want to intervene. And if they have persistent pain and failed non-operative management is another indication. In summary, pediatric back pain is common. The vast majority of them respond to non-operative treatment. Be suspicious for atypical presentations, and that's why it's important to do a very good physical exam and a very good history. When it doesn't make sense and you're worried and something's just off, make sure to investigate appropriately and treat accordingly. I'd like to thank you for inviting me to talk today. It's again been a pleasure through the Pediatric Society, or the Canadian Pediatric Orthopaedic Society and POSI to have this collaboration, and I look forward to working with you guys going forward. So I'll entertain any potential questions.
Thank you very much, Dr. Smith. That was a very, very nice talk. Excellent cases and, a very great overview of actually what is a very difficult topic, but you made it very easy, and with great examples. It's open for questions. So I'd, request all our other participants to please, address any questions they have.
So, Dr. Smith, if I could just ask a question, is that you did mention that in most of the patients with back pain, you would do a CT scan in kids because just look for any apophyseal injuries. So, any particular age limits you have that below which you won't do, or above a particular age you will avoid doing a CT scan?
Yeah, so I'm very cognizant that in general, we want to try and minimize the amount of radiation to pediatric patients. So I won't CT scan everybody, but I'll usually start with the MRI. If on the MRI, you'll see something just a little bit atypical on the MR, and then I'll definitely get a CT scan for those. And sometimes if it just looks like a small disc, but you're like, sometimes it just doesn't feel right, then I'll get an MRI or a CT scan as well. What we have at our institution is we do have a low dose CT, and I get it very focused to really the area that I'm looking. So I'm not going to get a full spine CT scan. I'll really try and get it focused just in the area that we're looking at.
And one more thing is there were a lot of, as we discussed, a couple of high-grade listhesis cases where you did show how they were managed surgically. So, do you prefer going to S2 AI in most of those cases?
Yeah, so if I'm going to do a type of reduction or if it's a really high grade, I fear that just having S1 as fixation alone isn't always strong enough to be able to hold it. And so if I'm going to go to the pelvis, I prefer S2 AI screws. I do them under navigation, so I don't have to do a larger, more lateral exposure. I find that the screw heads and the tulips through S2AI screws are a little bit lower profile as opposed to kind of iliac screws. And so those are my go-to for those. I realize sometimes, especially in young adolescent teenagers, that we may have to take them out later on if they're symptomatic. And I'm willing to do that once it's fused if needed.
Got it. Thank you.
Thank you, Kevin. It was a very interesting talk. But I always find the presentation of pediatric orthopedic surgeons very colorful. I mean, something different than what we as adult spine surgeons make it. It's very nice, illustrative. Anyway, congrats on that. How do you guys get into that, making that slide format? I mean, it's something what you undergo as pediatric surgeons, train?
Oh yeah, well, I mean, our practice is so much more fun than an adult spine practice. So I can't believe they pay me to go in and sometimes I just use it's engaging kids in play to get them to trust you and do stuff. So I don't go in and be like, oh, go down, touch your toes. I'm like, all right, okay, hop like a bunny. So I find that in my practice, it's very fun. I mean, like, look at the picture here, right? We're very colorful people. And my back did hurt a little bit after all the dancing at PosiCon, but it responded to non-operative management. But I do think that as pediatric orthopedic surgeons, we are colorful. We like to have fun. We like to play and we like to illustrate things. That's one thing that I like. I like it colorful slides and not just a lot of writing.
Good. My question is about the yellow flags which you put. I mean, yellow flags usually imply a lot of psychological aspect to the back pain. But can you just explain about the 3 or 4 yellow flags which you put and why they come under the yellow flag category in your mind?
Sorry, I'm not. What category? I didn't fully understand.
The yellow flags. Yellow.
Yeah. I'm not sure I understand exactly what that is.
You meant the patients has got either they can have a red flags or important thing
Right.
not to
Oh,
miss.
the yellow flags. Yeah.
Yes. You included 2 or 3 things, but some of them I thought are more of a red flag rather than coming to.
Yeah. I mean, yeah. The color of the flag, I guess, at the end of the day doesn't matter. I think if it's yellow or red, red for me is like bad. It's like infection, tumor. Like for me, that's red flag, and that's why radiculopathy. I mean, it could be a disc, right? So a disc isn't necessarily something bad, but it's something that increases your suspicion that something is going on that may or may not need surgery down the road. For me, a red flag means it's like more malignancy or infection. So that's why I included that. Sorry for the confusion, but I agree that there are worrisome symptoms that, will push you to investigate things more.
Okay. That's fine. How often do you need to operate on a patient with spondylolysis? Because now in India also there is an increasing youngsters getting into sports. Therefore, we are seeing children in the age of 15 to 16 years coming with back pain, incidentally diagnosed to have lysis. What is your protocol in these patients? I mean, how aggressively you treat conservatively and what are the treatment you take?
Yeah. See, our population is a lot smaller, but in my area in Ottawa, I mean, we're only a population of 1 million, which in Canada is a big city, but for you guys, is very small. I've been in practice for a dozen years. Our area covers about 5 million people. I have not done a primary spondy repair for a spondylolysis. I've been able to treat them all to date with non-operative management. And so I haven't had to fix one yet.
Can you just explain your non-operative treatment?
Yeah, so I'll usually prescribe them around the clock Celebrex, so a COX-2 inhibitor, for 6 weeks. I will give them also Tylenol. I prescribe them physiotherapy, so make sure that they get into one of our good physiotherapists that we have some kind of that we trust to teach them the exercises. I take them out of the sports for at least 6 weeks to give them a full non-operative management. And then realistic expectations that, listen, you have a spondylolysis, you're not going to be paralyzed or highly unlikely to be. And that if you can work through the pain, it's just pain. And so the vast majority of them, I mean, they'll wax and wane over time, right? Their pain, it'll come, it'll go, it'll come, it'll go. But as long as you're having more good days than bad days and it's not bothering you, then we don't have to do anything about it.
Okay.
And then if that doesn't work, then I've done a couple PARS injections. And it's either that the PAR injection works so well and then their pain never came back, or they disliked it so much that they don't want a surgery because it was such a bad experience from getting the PARS injection that they never want to see me again. But I'm not sure which one it is.
Okay. Thank you again.
Thank you.
So thank you so much, Dr. Kevin Smith, for such a fantastic lecture on pediatric back pain. I think which was one of the most comprehensive talks and a lot of which was covered. So thank you once again for being a part of the Pediatric Spine Academy and beginning with a fantastic second session or the second part of the webinar for this year round. So before we quit, just an update on the next session. So the next session of the webinar is on 3rd of July. That is the first Thursday of next month. And it will be on pediatric back pain by another authority in that field or the topic, that is Dr. Professor Rajashekharan sir. So hope to see you all once again next month for another interesting session of the Pediatric Spine Academy webinar. Thank you so much once again for being here. Thank you so much, Dr. Smith. Thank you so much, all the members of the Pediatric Spine Academy. And thank you so much.
Thank you.
Thank you.
Bye.
See you again.
Thanks, guys.
Bye, sir.
Thanks a lot.